So thank you very much for the opportunity to speak today. So my talk is all around the application of havening techniques in treating neurological disorders. So myself, I'm a certified brain health professional through the AIM clinics in the States, and a certified havening techniques practitioner. And if you wish to get hold of me, you can contact me via email or my website, and indeed I'll share my email at the end of this session. So just as a brief overview as to what I'll be talking about today, I really go into the neuroscience, and I'll try and make it as high level as possible to give you a broad understanding of how it really works. And then I'm going to go into the latest clinical research and results around the technique, and then finally talk about the application of havening for treating a wide variety of brain health struggles and neurological disorders. So the neuroscience behind havening, it really started with the two brothers, Dr. Ron Rudin and Stephen Rudin, trying to find the best therapeutic approach to helping people with major trauma, specifically people with PTSD. And they started looking at traditional approaches that are in use, such as EFT, which is tapping. And they came across, through 30 years of research, the approach of using human touch. And they've done extensive research around this, and the paper that talks about how this works is listed below. In essence, what they found through the detailed research is that delta waves are generated through the power of human touch. And there's a great paper by Harper that talks about the amplification of the delta waves against the baseline of resting state as a function of where you apply human touch to your particular parts of your body. And what he found is that you can achieve 90 times the baseline state when you actually touch your cheek, 5 to 38 times on your shoulder, and 5 times through the palms of your hands. And those are the 3 areas that are really used to help generate these delta waves in our brain. And specifically here is those delta waves are not amplified through the process of tapping on any other area of the body. And the only other mechanism that actually really generates an amplification of delta waves in the mind is through lateral eye movement. And lateral eye movement is typically used in eye movement desensitization and reprocessing. And that technique may also use vibrating pads on the palms of the hands, which generates 3 to 4 times the baseline of delta waves. And that's really important to understand, because it is believed that the delta waves produce an electrochemical response that allow a change in the chemical state within the amygdala where the traumatic event is encoded. So the requirements for traumatization are hypothesized as there needs to be 4 aspects to enable traumatization. First of all, there needs to be an event that takes place. That event has associative meaning attached to it by the person that perceives it. So in this instance, for traumatization, the person will have a perceived threat to life or limb. For example, a perceived threat that they are at risk. The landscape of their brain is vulnerable at the time that the event takes place. So what does that mean? Well, they know from previous studies that the landscape of our brain evolves through our prior experiences throughout life. So it can become more vulnerable if we are exposed to previous trauma. They note that through studies of children exposed to 9/11, that the landscape of the brain of children exposed to previous trauma made them more susceptible to having a trauma encoded from the 9/11 event. And then there's an inescapability associated with that experience or with that event, that that person doesn't feel that they're in a safe place. And when all 4 aspects of that are met, then there is the encoding of a traumatic memory. So how does the traumatic memory get encoded? Well, it's believed through the pathways through the amygdala. So the threat comes into the amygdala via the thalamus, with the exception of the threat that is smelt, that comes through the olfactory route. So the threat comes in via the thalamus through the lateral amygdala. The lateral amygdala then relays through to the basolateral nucleus, and that basolateral nucleus decides what our associate response will be, whether we are going to choose a survival response such as fight, flight or freeze, or we are going to choose a response that's defensive rage. So imagine a rat cornered and they have to produce a rage in order to escape. And this all takes place within the amygdala, that is very deeply located in the deep limbic system, and it's the size of two almonds. There's one on the left and one on the right hand side of the brain. So how does the delta waves then work? Well, first of all, for a traumatic event to be encoded in the brain, the sensory input from an event is transduced through an electrochemical signal. And this is typically high frequency gamma waves via the thalamus that I've just explained, that travels down the neuron. And then at the thalamoamygdala neuron, that releases then glutamate, which activates the NMDA receptor, allowing the calcium channels to be opened and the calcium to enter the cell. And that calcium influx into the cell itself is dependent on the wave frequency. And in this case, in the threat, it's gamma waves. This wave that comes in, which is a result of the threat, produces an intracellular calcium oscillation, and that brings AMPA receptors to the surface of the cell. And in essence, these AMPA receptors act as the opportunity for us to respond very differently. So I like to describe this simply as a short circuit, so that if we experience the event again, we can act very quickly. The traumatic encoding also activates a kinase, which is called PKM-zeta, and that's brought to the surface where the AMPA receptors are phosphorylated, and in essence they're glued, and that permanently anchors them to the surface, and that's called potentiation, and that's been researched quite significantly over several years. So how does that then work in terms of our response to the threat? Well, when we have the AMPA receptors are phosphorylated to the surface, our associate response will be in four different ways. We have a cognitive response, which is our thoughts, the meanings we prescribe to that event, our interpretations and perceptions. We'll have an autonomic response, which is how our brain functions and regulates our bodily functions. So that can be an increased heart rate, breathing rate, sweating and muscle tension. So our autonomic nervous system comes into play. Then we may have a somatosensory response, which is sensed through the body as pain, tingling, numbness and other sensations. And finally, we have the emotional response attached to that event. And depending on the person's landscape of their brain, depending on their position within the event, depending on the meaning they attach to the event, will all influence what the outflow is from a cognitive, autonomic, somatosensory and emotional perspective. And key here for the clinical research that I'll be talking about is it's very much focused on measuring the autonomic response associated with the traumatic encoding that may have taken place. But there is vast opportunity from a research perspective to measure the other aspects of the outflow that happens as a result of response to a threat. And in particular here, from a cognitive perspective, we may be considering the use of fMRI, SPECT and PET, as we heard from previous speakers, to facilitate our understanding as to how the outflow works and how we can reduce that outflow through the use of havening or other techniques. So how does the decoding of the trauma in the brain work then from the application of human touch? And in particular, we're talking about havening touch, which is the application of just gentle stroking to the face, to the arms and to the hands to generate those delta waves that were measured by Harper through QEEG studies. So the activation of the encoded pathway is happened by recall. So this is done from a havening techniques perspective deliberately. We ask the individual to recall the unhelpful experience or event, or it can happen inadvertently. And so that's done by the working memory that releases the glutamate at the surface of the natural nucleus of the amygdala. This then depolarizes the membrane via the NMDA receptor that's mediated through calcium influx, and it activates the AMPA receptors, and critically here it exposes the anchoring phosphate. So that's the glue that binds the AMPA receptors to the surface. Then what happens when we apply havening touch through stroking the face, the arms or the hands, is we have these delta waves travel through the neurons, and they activate then the voltage gated calcium channel responds to the really low frequency wave, which is 0.5 to 4 hertz by havening touch, and that produces a calcium oscillation that is decoded by calmodulin. That then transforms the calmodulin into a protein that activates the phosphatase calcineuron, and the calcineuron then dephosphorylates the AMPA receptor, removing it from the surface. Ultimately, it unglues it, making it no longer available for transmission of the information to the basal lateral amygdala, and that then obviously facilitates the decoding of the cognitive, the autonomic, the somatosensory, and the emotional content that is the outflow from that event. So how is havening touch applied to yourself? Well, it's easy to apply, so easy in fact that children are now learning to do it. So as I mentioned, simply it's through stroking the surface of your face, stroking your shoulders, and washing your hands, and just the palms of your hands. As we found from the research by Harper, we can generate up to 90 times the baseline on our face, up to 38 times the baseline by stroking our shoulders, and up to 5 times the baseline by washing our hands in that way. And my daughter, in fact, Lily, she's pictured in the middle here, and she learnt this technique at 18 months old, and she uses it now, and she loves it to help calm her down. So what's the clinical research behind havening techniques? Well, this work was done by Kirsty Hodgson and co-workers. It's a clinical research trial that is ongoing, and they undertook a psychological examination of the mutability of type D personality, which are people that are prone to stress, anxiety and depression, and that was done in a therapeutic trial with a statistically significant number of people taking part in it in order to validate the results as being meaningful. So the aim of the study was to investigate the efficacy, as I said, of havening techniques on type D personality, and also biomarkers in association with that. So here we're looking at the autonomic response. The method, I'm going to talk about the participant demographics. The procedure key to this is it was a statistician blind parallel group controlled trial where they had participants versus a waiting list control group. And I also go through the approach and associate results. So in terms of the participant demographics, key to this is the sex distribution of the treatment and waiting group was very similar. So that's really important that we don't have any known variability in terms of the participant demographics, excuse me. In terms of the procedure, 125 people were recruited, 68 were allocated to the treatment group and 57 to the control group. A baseline measurement of the criteria for type D personality, that's DS14, was taken prior to the application of havening techniques. Post-treatment, that was a day after, and a follow-up measurement was taken a month later. And ultimately, based on the participant dropout. They had an analysis of 121 people. So the approach was a brief activation of the distress to initiate the neurochemical response from the amygdala. They asked the individuals to apply havening touch. So these are the people that were in the havening group. And as I said, those delta waves generate a response of 0.5 to 4 hertz. At the same time, distraction techniques were used, using metacognitive multisensory input to allow the delta waves to do their work within the amygdala without any further activation from the working memory. And then they looked at the associate biochemical markers and the DS14 measures to understand how much the type D personality conditions had changed as a result of havening versus the control group. So these are the results. So these are the participants meeting the type D caseness criterion. And you can see in the red line is the waiting list group versus the treatment group who received havening. And you can see there's a statistically significant difference between the two groups within 24 hours, and also a further decline over the period of 1 month later. Also extremely interesting with regards to this study was the biomarker outcomes from the application of havening. Is in all cases we see a reduction in the diastolic and the systolic blood pressure, the heart rate and the cortisol levels. Now the cortisol levels were the saliva, measured through saliva, so as not to induce any stress response through taking cortisol using the blood. And we can see that based on the standard error bars, a statistically significant difference between time point 1 and time point 3 in all of the cases. Qualitative outcomes, considering the biopsychosocial model, which looks at all the elements shown in the circle here. People reported, my headaches have gone, the stress is still there, but I'm not stressed about it, very strange. I feel lighter, I'm feeling hopeful, I can see a way through, I care more about living, I've got my sense of humour back. I don't know what she did with my pain, but it's gone. And this is very common language that I hear from people who have received havening from myself through a variety of different brain health struggles that they're experiencing. So what does this mean in terms of application for of havening for treating neurological disorders and conditions? Well, this technique can be applied from pre-birth all the way through to your last birth, but particularly from my personal experience, my daughter Lily was born by a cesarean section, experienced nightmares from birth as a result of her birthing experience. And it wasn't until applied havening to her while she was experiencing her nightmares that those nightmares went away. As an example, and there are many other examples of regards to this. Havening is a great approach to help with stress, anxiety and depression. I've helped individuals with post-traumatic stress disorder where all other treatments have failed, and after a follow-up 3 months later they no longer had the flashbacks that were removed in just one session. Childbirth trauma for both parents and child is very effective for that. Childhood and domestic abuse. First responders experience chronic stress and anxiety as a result of their working conditions, so it's extremely helpful not only from the immediate trauma that they experience, but we know that the landscape of the brain becomes more vulnerable the more trauma that we layer onto the brain itself. Trauma from natural disasters, so I've been helping people in a group context who have experienced major natural disasters, and the great thing about this in a group context is because you're asking the person to bring the event to their mind and it's the specific event that they want to focus on, it's very focused and localized to the struggle that in particular individual is having, and they don't have to say anything about their experience in order to achieve the benefit, providing they're applying havening touch. So you can do it in a group context, content-free, and many people report a reduction in their distress level of 8 out of 10 to 2 out of 10 in under an hour. It's incredibly helpful for bereavement and grief. I myself experienced havening after losing my dad, and went from a distress rating of 7 out of 10 to 2 out of 10 in just one session. Great for medically diagnosed illnesses and diseases. So people who've experienced trauma through being diagnosed with cancer, for example, I've helped people in that context. Physical pain from a traumatic event can often have a psychological component to it. So havening can be used to help remove the psychological aspect that is encoded in the amygdala, encoded in the brain, to help provide some relief. Chronic pain is often considered to have a strong psychological component to it. And so it's very useful in helping people with chronic pain. Obviously, further research is required with regards to that. Sleep disorders, delta waves are generated during deep sleep, where our brain undergoes the cleaning that it needs and the reshuffling of the memories. And it's often reported through my clients and many other havening practitioners that people sleep very deeply following havening. So it has the opportunity to be used to facilitate people with sleep disorders. Bruxism, teeth grinding. A client of mine stopped teeth grinding after a single havening session that was brought upon when they thought about the particular trauma that they experienced. Have another client who has ADHD, and they have a particular type of ADHD. So there's 7 different types of ADHD. A particular type brings not only drops the prefrontal cortex, but results in overactivity in their deep limbic system. So they find it very powerful to calm down their deep limbic system and help bring back their prefrontal cortex online. And also application in autism, which has been used by other people applying havening techniques, and the list goes on. But clearly further research is required to truly understand how far-reaching this capability is, particularly as it is able to uniquely target the event that the person brings to their working memory that has caused them the traumatic experience and the associate encoding as a result of that. So what are the conclusions from this? Well, the results by Kirsty Hodgson and co-workers demonstrate there's statistically significant results in a large trial. They offer really great promise in the application of havening techniques for treating multiple brain health struggles. However, we are really at the forefront of research in the context of the application of havening techniques, and also really the understanding of it as well, how it really works, and at molecular level. And much more research is required to really understand the extent and the breadth of this approach to really treat a broad variety of conditions. And the list at the moment is continuing to grow. And what's unique about this in the context of some other therapeutic approaches is, as I mentioned earlier, is there is no need for people to say anything about their experience for the approach to work for them, and they don't have to believe in the approach for it to work either, as has been the case with many people I've helped. And because of that, it has the power to really radically change the way we treat neurological conditions without the need to talk, and also without the need for medical intervention, by virtue of the fact it can be very targeted to that particular neuronal pathway where the trauma is encoded and the associate pathways that are related to the outflow of the traumatic event that is encoded throughout the brain through the cognitive, autonomic, somatosensory and emotional response. So that concludes my talk. In terms of acknowledgements, I'm really grateful for the support of Dr. Ron Rudin, who's really the pioneer in understanding and inventing the havening techniques approach to helping people with traumatic experiences, to Kirsty Hodgson for sharing the fantastic research that she's done, and also to John Kennedy for encouraging me to attend this conference. Thank you very much. Does anybody have any questions?